Thank you, Dr. Shanmugam. First of all, you saw the slide and realized it's your own photograph and was very surprised. Thank you, Dr. GVK sir, for giving me an opportunity to be here today and talk to you about something interesting, that is cardiomyopathy and diabetes. We keep hearing about heart failure and diabetes, cardiomyopathy and diabetes. So many things keep cropping up. So I thought I will take you through a simple everyday common garden case. A 60-year-old male, diabetic 10 years, hypertensive 20 years, breathlessness on exertion, obese, BP fair control, the usual drugs, EGFR is 69, urine albumin creatinine ratio 220, TMT positive, CT angio showed a 70% lesion. So because of breathlessness, echo was done, EF was 58% and they've reported as grade 2 diastolic dysfunction. So essentially you have obese, diabetic, and you also have a renal involvement and coronary artery disease. So there is an interplay between the kidney, the heart, and the obesity. So there is essentially a cardio-renal metabolic syndrome overlap. And if you look at the percentages, I will not go into specifics. There is a 20 to 40% overlap across the board, different subsets. There is an overlap here. And in diabetes, whenever you start looking at it, you will see that one of the commonest manifestations are the kidney disease and the heart failure. So now the AHA Presidential Advisory has come in clearly stating a new term which Jayashree had alluded to, which is the cardiac kidney metabolic syndrome. And in the stage 1 is just obesity. So dysfunctional obese tissue or dysfunctional adipose tissue is stage 1. And the stage 4 is manifest clinical disease, of which 2 are very important. The coronary artery disease and 2 is the heart failure. So these are the 2 important things we are interested in. And if you look at the 2 diseases, if you look at atherosclerotic cardiovascular disease, the highest risk, very high risk category carries a problem of about 7% risk of events. But look at the extreme risk of heart failure, which is nearly 40 to 50% mortality. What it means is, compared to atherosclerotic cardiovascular disease, the heart failure is a bigger killer. Looking into clinical practice, if you look at diabetes without heart failure and with heart failure, look at the steep difference in the curves. The heart failure fares much, much poor. They fare very badly. Survival is poor. Going back to our case, we have a diabetic hypertensive and we said the EF is about 58% and diastolic dysfunction. How do you clinically start suspecting? The classical symptom of heart failure is going to be breathlessness. Orthopnea, PND are going to happen much later. The symptoms of congestion, which we have learned in our MBBS, are not routinely there in clinical practice. It's just going to be breathlessness that you're going to find out. When you look at routine assessments, 2 things stick out. 1 is your echocardiography and 2 is your natriuretic peptide. The natriuretic peptide, I just want to give a word of caution saying, in the right patient, if you do it, it is beneficial. So if a patient has a problem, you show that the natriuretic peptides are high, it is going to be beneficial. Otherwise, it may not be a true story. So in a diabetic with suspected heart failure and cardiomyopathy, how does this term diabetic cardiomyopathy come in? Now let's go into the genesis of this. Originally, the diabetic cardiomyopathy was thought of as a dilated phenotype. Dilated heart, LV dysfunction was dilated cardiomyopathy. Now we have evolved into a different subset according to the heart failure clinics. It says it's a restrictive phenotype. The heart functioning is normal. It's just a diastolic dysfunction or a heart failure with preserved ejection fraction. Now, how does this work? There are 2 stages of heart failure. One is the early stage, wherein there is a concentric left ventricular hypertrophy, diastolic dysfunction, and increase in LA pressure, the classical pressure. Advanced stages can go in for more advanced diastolic dysfunction, systolic dysfunction, LV ultimately gets dilated. So this is the advanced stage. And the pathogenesis is huge. Like you look at anything related to diabetes that has been spoken of today, everything is put in this slide. So I will not go into this. I think leave it at that. But this concept is not accepted by everybody. The Seferovic and Paulus article has clearly said there could be 2 types of diabetic cardiomyopathy. One is the restrictive phenotype and the dilated phenotype without the restrictive happening. That can also happen. So what is the difference? Histopathologically, herein there is a reactive fibrosis in the restrictive type, whereas it's a replacement fibrosis. The cardiomyocyte is gone, the LV dilates and produces severe LV systolic dysfunction. So there's a pathological difference which can happen. Both can happen in patients with diabetes. Going back to our case, our main pathology now seems to be heart failure. So in heart failure, we are talking about heart failure with grade 2 diastolic dysfunction. Can you predict which patient is going to have heart failure? Now, there is a particular score called the WATCH-DM score. Now, if you look at this age, systolic BP, BMI, glucose, diastolic blood pressure, and HDL cholesterol, serum creatinine, if you look at all these factors, and as the number of score increases, higher is the chance of a patient having heart failure and diabetes. So this score will help you sit in your clinic and know which patient you should be sending for further investigation. The diagnosis of heart failure with reduced ejection fraction is very easy. Do an echo, EF is less than 40%, you have reduced ejection fraction. But heart failure with preserved ejection fraction is not easy at all. It has to be a clinical signs and symptom with a lot of other factors that have to be determined. Now, if you look at this, there are two scores, the H2PF score and the HFA-PF score. The simplest is probably the H2PF score, wherein you look at multiple factors like heavy patient having an obese body mass, hypertension, atrial fibrillation, pulmonary hypertension, elderly, and filling pressures being high by echocardiography. You look at all these factors, then make a diagnosis of heart failure with preserved ejection fraction. Sitting in your clinic, will you do this? I wouldn't do that. So what do? You look at echocardiography. I'm a lazy fellow, I have an echo machine in my clinic. And when I do an echo, we look at the E by E prime, which is equivalent to the LVEDP. But that is not accurate. Look at the red line here. What is this? This shows LA reservoir strain. How many of you have seen an echo report with the LA reservoir strain? I'm sure nobody has seen LA reservoir strain in your echo reports. Now, if you look at the LA reservoir strain, you need a pretty advanced echo machine and a dedicated echocardiographer who does the LA reservoir strain, which is the most accurate parameter for the relaxation abnormality. So if you have suspicion, send it to a cardiologist who's got a strain imaging and ask him to do LA reservoir strain. That is going to be useful. How often do you notice this? Nearly 46% of diabetics have heart failure with preserved ejection fraction. Now, different data have shown nearly 44 to 46% heart failure with preserved ejection fraction, while the heart failure with systolic dysfunction or the reduced ejection fraction is only seen in about 30-31% of patients. So this is a much bigger problem which is not recognized. We are not looking at it because we don't know about it. And if you understand how to treat it, the drug that comes into picture is the SGLT2 inhibitor, which Dr. Shanmugavel has been telling again and again, put this here, put this there. Why? Because of this. Now, SGLT2 inhibitors have evolved. Initially, it started off with the cardiovascular outcome trials, which are mandatory post the rosiglitazone fiasco. And then it has been shown in heart failure with reduced ejection fraction, preserved ejection fraction, and now it's gone beyond, and now we say whether you're diabetic or not, all these patients should get it. In fact, last week I gave a talk and told probably you should mix it in water and give it because it seems to be working in all diseases. You will be surprised. It works in polycystic ovarian disease. It seems to be working in atrial fibrillation, ventricular fibrillation. You name a disease, there is some benefit of the SGLT2 inhibitors. That seems to be there. There are data to say that. So when you look at how the heart failure is treated, classically we look at 4 factors. Reduce the preload, reduce the afterload, increase the contractility, and reduce the heart rate. Now, of these 4 parameters, the SGLT2 inhibitors are going to work at reducing the preload, reducing the afterload, and effects of the myocardium that improves the contractility. So it seems to be having predominant effects. I will not go into specifics and read out all these things. So it has definitely got action on the entire spectrum of heart failure management and the pathophysiology. The empagliflozin has also shown an improvement in the EMPARAG outcome trial. Patients with known heart disease and cardiovascular disease and diabetes. This is the only drug which showed a 38% relative risk reduction in MACE. It also showed mortality improvement, and this actually in the Asian subgroup showed a 56% relative risk reduction. Now, this is very interesting. The overall population was 38, but among the Asians, the empagliflozin seems to be acting much better in these group of patients. So if you look at the primary outcome trials, EMPARAG, the CANVAS, and the DECLARE-TIMI, and the VERTES with different drugs, this is the only drug that has shown the effects with the major cardiac events, cardiovascular death, all-cause mortality, the heart failure hospitalization, and the renal outcome. So this drug seems to be working across the spectrum in patients with cardiovascular disease. Now, SGLT2 inhibitors have also, like I said, been studied in heart failure with reduced ejection fraction, mildly reduced ejection fraction, and the preserved ejection fraction. Mildly reduced is the group between 41 and 50%. So if less than 40 becomes reduced, more than 50 with heart failure symptoms become preserved. And across the board, these drugs reduce heart failure hospitalization by nearly about 30%. So that is significantly reduced. The empagliflozin has also been studied in hospital. When you're admitted with heart failure, don't wait for discharge. Before discharge, you can start these drugs. They also improve diuresis. In an acute heart failure, give these drugs that will improve the diuresis also. And long term, it has also been shown to reduce mortality and subsequent heart failure hospitalization. Now, this is the classification of heart failure I was talking to you about. Since I said there are 2 types of diabetic cardiomyopathy, basically the reduced ejection fraction and the preserved ejection fraction, the management of reduced ejection fraction has become very, very easy. We call it the 4-pillar management. 4 pillars of management of heart failure. I'm sure all of you have been hearing this again and again. use of ARNI, the beta blockers, MRAs like the spironolactone and the eplerenone, and the SGLT2 inhibitors. Now, how important it is. If you put these patients on all the 4 drugs, you just need to treat 4 patients for 2 years to save 1 life. Now, mind you, I'm talking about mortality. So if you treat 4 patients, you're going to save 1 life. This is not there in any other study so far. So such is the impact of heart failure management. All you have to do is put these 4 drugs. Now, mind you, I'm talking about heart failure with reduced ejection fraction. That is important. Now, clinical question is, I will tell you this, you can't start all 4 drugs together. So which one to start? Now, the conventional wisdom was which drug came first was started. First the ACE inhibitors came, then the beta blockers came, MRAs came, and the SGLT2. That is how they were starting. But now recently, Milton Packer came up and gave this rapid sequencing. He says, at first start beta blocker and SGLT2 inhibitors, next add ARNI, and then finally go for MRA. But this is not going to work in all patients. The reason why they gave for this was when you give SGLT2 inhibitors, the side effects of the ARNI and the MRA, namely the hyperkalemia, is reduced significantly. So they say give it like this, but that's not going to work. There are multiple other proposed mechanisms. So what we are trying to do is we are trying to make one size fits all. One mechanism does not work. So finally, what is, I think, practical is going to be what is called as the Miller's hypothesis in the management of heart failure. What is Miller's hypothesis? They change these patients with heart failure into 3 clusters. If you are congested with fluid overload, give them diuretics and SGLT2 inhibitors. If you are hypertensive, if blood pressure is very high, start ARNI. ARNI is going to reduce the blood pressure, and add MRA, which is also going to reduce blood pressure. If you're tachycardiac, those patients should be started with the beta blocker and ivabradine. So I think it makes practical sense. I think this, is the most practical way of managing heart failure. But remember, if your patient is congested, the diuretics are very, very important. That you must remember and start. And how soon to start, how early to change, I think within the first 28 days, all 4 drugs must be on board. That's important. A small dose of all these 4 drugs is more important than all the 1 drug in full dose, because there is additive effect of these drugs, and they should be given consecutively. And you must also remember that among the 4 drugs, the easiest drug to titrate in practice is the SGLT2 inhibitors. There is no 5 milligram dosages. Please remember there is only cardiac benefit, and cardiac data is with 10 milligram of empagliflozin or dapagliflozin. So that is very, very clear with this. So what does the guidelines say about prevention of these problems? Guidelines have used several data. One, they look at, very importantly, multifactorial risk factor management. And if you start looking at all the factors, the important thing is anybody with ASCVD or high risk for ASCVD. What is high risk for ASCVD? If you're diabetic with any other risk factor, let's say hypertension, smoking, or let's say you're obese, any of these additional risk factors if you have, or even a microalbuminuria, you are more prone for problems. All those patients must be on an SGLT2 inhibitor or a GLP-1 agonist. So SGLT2 inhibitors are more tablet-wise. They are now off patent, very easily available, and that I think should be very important in clinical practice. And please don't worry about side effects. In fact, in non-diabetic patients, I've been very, very comfortable using SGLT2 inhibitors. Nothing happens to them. They don't get any side effects. So in diabetic patients, it takes a little bit of patient education to start treating this. But what is more important is, it's not a single factor management. It's sugar control, BP control, lipid control, and additional drugs to prevent further heart disease. Even RAS inhibitors are very, very important. So don't look at one aspect. The diabetologist doesn't stop with just controlling the HbA1c. You should look at prevention of heart disease and kidney disease, which I think should be paramount in your mind. Now, several guidelines, the 2024 guidelines, are also stressed the importance of SGLT2 inhibitors, not only in the presence of heart disease or heart failure, but in all high-risk patients. I think there is no diabetic who's called low-risk diabetic. Diabetes starts with moderate risk. The moment you have one other risk factor, you become high-risk diabetic, which I'm sure everybody's got. So all diabetics will technically require an SGLT2 inhibitor. Please start them. It will prevent patients from coming to me. And among the drugs which reduce MACE, only 2 drugs have been proven, the canagliflozin and empagliflozin. Other benefits are clear. I'm stating this because empagliflozin, in the absence of a major heart failure, seems to be the only drug that seems to be reducing MACE, and very important. And the level of evidence for heart failure with reduced ejection fraction is class 1A. That is important. There is some difference between these drugs. And why SGLT2 inhibition? I think I've made enough case to tell you there is innumerable number of studies wherein it is proven beneficial. How does it work? It seems to be working on all 3 pathways, and it also has several benefits. Like every day you look at the circulation journal, there is one paper talking about some mechanistic effect of the SGLT2 inhibitors. It just seems to be going over and over again. Thanks. think the weather is kind of hitting me today. So when to use this drug? I think all diabetics, unless there is a contraindication, your eGFR is less than 20, must be started on a SGLT2 inhibitor. Any objections from anybody, I'll take it later. So finally, to summarize the differences between heart failure with reduced ejection fraction and preserved ejection fraction management. ARNI, MRA, beta blockers, SGLT2 inhibitors are class 1 indications in reduced ejection fraction. But what about preserved ejection fraction? Diuretics for both whenever there is congestion. Otherwise, there is no role for diuretics in stable patients. All heart failures need not be on diuretics. Please understand that the indication for ARNI is still 2B. Might come to 1 because there's one more study that is published recently. MRA in a specific subgroup of patients. There's one trial called the TopCat trial. It was beneficial in heart failure with preserved ejection fraction in the obese phenotype and women. That's one subgroup that is beneficial. Beta blockers, I have left it minus because actually in heart failure with preserved ejection fraction, a higher heart rate is beneficial. So if there is some other indication for beta blocker, use it. But otherwise, actually, a higher heart rate is beneficial. Don't put them unnecessarily on beta blockers. SGLT2 inhibitor is probably the only drug, according to ESC, with a class 1 indication in heart failure with preserved ejection fraction. The last question that I wanted to, last slide was on this particular trial called the revived BCS trial. Remember the patient that we were discussing about had a 70% lesion in LAD. And I never spoke about revascularizing this patient because there is one big data which has gone ahead and shown that if you do a PCI or not do a PCI in patients with heart failure, there is no significant benefits. So the bottom line is that you don't have to send it to a cardiologist. As a diabetologist, if you're sure, you can still treat these patients, but get to do an echo properly. Final takeaway, whatever I have said, diabetic cardiomyopathy, suspect in the obese, multiple risk factors. I'm specifically talking about heart failure with preserved ejection fraction. Any breathlessness with high risk features, get a proper echocardiography done. Don't get an Amke echo. And there are two kinds of heart failure, reduced ejection fraction and the preserved ejection fraction. A properly done echo with the LA strain is the best. There are several times in my clinic I have noticed these older patients with breathlessness, LA strain is reduced, do an NT-proBNP, NT-proBNP is elevated, just put them on a small dose of diuretic and SGLT2 inhibitors, their breathlessness definitely improves. And empagliflozin, significant benefits in cardiovascular disease. And one often forgotten feature in the management of heart failure is anemia. Anybody with hemoglobin less than 12 in a female or less than 14 in a male, sometimes even those, despite adequate treatment, look at serum ferritin levels and TSAT levels. You correct them with parenteral iron because oral iron doesn't work. Symptomatically, they improve tremendously. With that, I think I should say one final message. The eyes only see what the mind is prepared to comprehend. So if you understand the disease, you're going to make this diagnosis. Thank you very much for the patient listening.